I'm a patient advocate, don't always know the way through to these things. We have patients who have liver tumours that are very close to important blood vessels, etc. And HIFU would seem to be a therapy that could potentially be the remedy for them. How would a patient attach themselves to the Oxford Churchill Hospital and actually, if it was an urgent need, get onto one of the trials that could perhaps give them the solution to their problem?
I think the direct approach is always good, and I think there are the oncologists in the Marsden will know the oncologists in Oxford, and I think the direct referral pathway is good. It's about what trials are currently ongoing and about selection criteria. At the Royal Marsden, in the Sutton branch of the Royal Marsden anyway, they've just taken receipt of the latest MRI-guided focused ultrasound device at the Sutton branch. And so we are going to be collaborating, and we, that is North London Cancer Services, are in talks with the Chinese device manufacturer that's in Oxford to get one at the Royal Free. And so the number of centres that are having these devices are increasing, and the idea is that there'll be a collaborative approach so that more patients can become part of it, because the problem is with rarer disease types, to get a trial is difficult, and to get funding for treatment for what is not a proven or funded tech is difficult. And so I think the bottom line is everyone will take it on a case-by-case basis, and if there is a decision made locally saying we don't know how to address this, it needs to go through the normal London sarcomal sort of GIST pathway, and hopefully those communications will be made. But it's up to, I think, the patient advocates as well to be aware of all the tech that's coming out and to be able to flag it up, because often you will be ahead of the curve than the people sitting behind the desk, because there are so many pockets of enterprise coming out all the time, which I'm not aware of, that it's difficult to get a handle on exactly what's going on where. But I think once you know about it, inquire, and because someone will know someone to be able to make the inquiry for you.
Do the tumours have to be a certain size, or can they be larger?
So for the targeted treatment with microwave ablation and the needle ablative stuff, normally say over 3 centimetres you're pushing it, but you can treat up to 5 centimetres or bigger. With HIFU there is no theoretical upper limit, but of course there are other factors to be involved. Whereabouts it is in the liver, the things it's next to, because it's not without its own complications. Even though it's non-invasive and doesn't involve a needle, you've got to point it in the right place, and it's not going to move around when you treat it. So HIFU is still an experimental tool. Okay, this isn't in general circulation. There are some significant technical issues which need to be overcome before it comes into the mainstream.
Can you do more than one? Could it do multiple tumours?
Yeah. Again, it's a matter of time, because it's slow.
Yeah.
That's the trouble. Yeah. It's slow. Certainly compared to the direct sort of needle approaches, it's slow.
What do the patients feel when they're being zapped?
Not a lot, because general anaesthetic is a wonderful thing. Not for me personally. But generally speaking, it's actually very well tolerated. And the patients who we treat who have got liver tumours, for instance, the vast majority will wake up afterwards with a plaster on, have a bit of discomfort, maybe a bit of shoulder pain, and then stay overnight and be home the next day.
Do you know if they're using any of this at the Christie Hospital in Manchester?
Yes, I don't know to what extent, but certainly we have got links with the Christie, certainly on the vascular oncology, so the delivery of the embolic particles. We're working with them at the moment on a collaborative project.
I'd be interested to know how many people here had RFA.
I can't answer that. Hands up if you've had RFA.
Relatively few, but early days, I think.
I had something called the nano knife.
Yes.
It's a little bit like an RFA, isn't it?
Well, nanoknife is one of the sort of things that's being investigated at the moment, and it's like RFA and microwave and HIFU heat up the tissue to destroy it, so the tissue is cooked, essentially. Nanoknife is different in that you have multiple needles inserted into the tumour and then have a very high voltage but low ampage pulses across the needles. So it's like arcing. And you have up to 90 pulses in a session, but you need to be paralysed when this happens because it's like, you're being electrocuted. But because it's very low ampage, you don't actually destroy the tissue. So it's not a heat effect. What the electric spark does is it opens up the cell membranes and the cells then auto-destruct. So you don't end up with a big, soggy, cooked scar. The cells auto-destruct and then it just all gets eaten away. That's the theory. But it's quite recent. You're ahead of the curve.
That's what the hair was standing up on when I woke up.
That'll be it.
Last year.
2 weeks ago.
Talking about using these techniques on liver tests, what about just in other parts of the body?
Yes. I mean, I was talking about liver gist there because that's the place where they go to that can be targeted, essentially. Peritoneal deposits, so deposits around the bowels or in the pelvis, any solid tumour deposit can be targeted. So, generally speaking, we don't like pointing lots of energy at guts, because if you make a hole, there are issues. And so, primary treatment of stomach gists, using the kind of techniques that we're doing, we don't like, because we need the body to be able to heal itself and not fall apart. And the problem with the TKIs, the imatinibs of the world, I'll make a shameless plug to Alex Lyon's cardio-oncology unit now, and that Alex and I were colleagues from medical school, and he now runs the cardio-oncology centre at the Brompton. And he describes it very nicely as the yin and yang of medicine, in that what is good for the heart is generally bad for cancer, the other way around. What's bad for cancer is generally also bad for the heart, and what's good for the heart is generally good for cancer. And so what you're aiming to do is to stop a rapidly dividing energetic cell. That's what cancer therapy is, and that's what heart is at the same time. And so that's why imatinib, it gives you cardiotoxicity, is because essentially it's a highly energetic turning over cell, and that's exactly the thing that you're stopping. And when you've got these tyrosine kinase inhibitors on board, it also stops you healing quite so well. And so if you're sticking needles in and destroying and then relying upon your own body's own immune system to get rid of them and to knit them together and form a scar, you want your body's immune system to be on top of its game. And so, again, not only do you want to avoid making holes in bowel, you've also got to make sure that you can heal up afterwards. Yeah, so I put a needle in through the skin and through the liver and actually stab the tumour itself and then treat the end of it. The vascular oncology is what you're talking about, where it's an indirect way of getting to it. So you go in through the groin and actually trace the blood vessels up with a tiny catheter, and then you inject tiny particles into the tumour blood supply or into the hemangioma blood supply in order to block them and then shrink the tumour down. But that by itself is rarely effective to treat the lump. It may shrink it down a little bit, but the problem is in the liver, is that tumours in the liver have multiple sources of blood. And so even though you block the arterial supply, there are other feeders into it. So it may shrink it down a little bit, but it rarely treats it in its entirety. But that's why they're now loading these tiny particles with high-dose chemotherapy. So not only do you block the blood supply, shrink them down, you then give it a massive whack of chemotherapy, which then has a local effect. But they're not doing that with GIST yet. They're doing that with things like primary liver cancers and cancers that are spread from the bowel.
It's just that this gut is that I was a huge 6'4" American guy with a Scottish name. I was quite surprised when he mentioned what he was
Yeah. You may have done.
What you said just now about the nano knife? sounds like that's for bigger tumours, or
Again, there's no theoretical upper limit of the size you can treat. It's just a matter of how many needles you can get into the lump. And so where the nano knife is being used, generally speaking, it's a piecemeal effect, otherwise you end up looking like a porcupine. So you treat, you can put in up to, 7 or 8 needles and treat it, and you've got to have a certain distance between each needle. But patients tend to come back for sort of multiple goes. I don't know how many treatments you had.
It was initially on the biggest tumour at the time was 9 centimetres, so they were going to do it in 3 stages, in like 3 thirds. But unfortunately, I had a little bit of a reaction afterwards, so I didn't continue the treatment. But scans afterwards did show that that part did have some kind of response. So it's a shame it didn't really continue. So.
Yeah. So. Okay. So yeah. So a lot of these tech. Okay. So a lot of this tech, because it doesn't involve radiation, can be repeated, and so you can treat it, and even if you do leave some tumours left behind, or you can do it in a staged approach where you deliberately target one bit and then you come back and you treat the other bit.
Are there any further questions? Well, I think we'd like to thank you for a fantastic talk and real hope for the future. I think it's just become a major feature